So it's said to be a symbol of our country, the thing that makes being a Canadian so great. It consumes darn near 50% of government operating budgets, and no one is happy, ever. So in the never-ending attempt to rein in costs, which always seem unsustainable, everybody points a finger at everybody else. It's the fault of high-cost, complex, ultra-modern drugs, some people say. Others point the finger at the doctors and say it's their fault because of their ever-escalating, incessant demands for higher fees. Still others say it's the fault of the seniors who are going to break the bank with the costs of taking care of their decaying and dying bodies. Yes, boo. So to unpack what I think Winston Churchill called a puzzle wrapped in a riddle inside a conundrum, I've turned to two of the most lucid thinkers in this field that I have personally encountered. One is André Picard, the journalist who's spoken on this stage, and the other is the former CEO of Shoppers Drug Mart and the current CEO of McKesson, another major drug retailer and wholesaler. So, Dominic is a Montrealer, and he and I first got to know each other over a smoked meat sandwich. And that's when he began to tell me about these very eye-opening and eye-popping things which he's going to review with you right now. This is Domenic Pilla.
Thank you, Moses.
Pleasure.
I met Moses a while ago, and I'm hoping that he still thinks all those special things after the next 17 minutes. So hopefully that will maintain your... But thank you for being here. Thanks for giving us the opportunity to talk about what is dear to Canadians, and certainly dear to me. I'm a very proud Canadian. Canada's been very good to me and to my family. We think I owe the country everything. And I want to talk a little bit about my journey. And every one of us has a journey around healthcare. I want to talk about my journey and why I'm here and why I think Moses invited me. About a year and a half ago, after what I thought was a successful career, met all my ambitions and all my needs from a professional standpoint, and I got in another different part of my life. I retired, and my wife, oh, thank you. And my wife and I decided to do something that we were coveting to do our whole lives, and we commissioned the build of a sailboat, and we went sailing full-time. And I did that for about 2 years with my wife, and it was a fantastic. We've been sailing our whole lives, and this was an opportunity for us to really do this full-time and at different paths in our journey, in our life. And about 2 years after I started to do that, and my plan was to do that with my wife for the rest of our lives, I got a phone call to become CEO of McKesson Canada, which is what I'm doing now. We've assembled these assets in Canada, and we'd like you to come and run them. Because you're CEO of Shoppers, you were at McKesson before, you were at Petro-Canada, I had done this leadership type role a lot, and I said no. I'm not interested, I've made a decision. We were actually in Palma, Mallorca, and if any of you have been there, it's paradise for sailors. We were on our own boat, it was a new path that I had selected, and then that night, I couldn't sleep. I couldn't sleep that night because I was thinking of Canada's healthcare system. And I was thinking about my daughters who have started their careers and their lives, and 20 years from now, they might need a service, a product, they might need the healthcare system. And I knew that the way the healthcare system is currently structured and organized, they're likely not going to get that service. And how would I feel 20 years from now if I had turned down the opportunity to come back to Canada and help improve the healthcare system? How would I feel if I never took that opportunity and I couldn't sleep? I couldn't sleep because the system needs it. It needs all of us, it needs all 35 million Canadians to make it better. And it is part of our identity, but all of us are affected by it. And so I called him back the next day I said, I'm going to give it a shot. I just could not sleep with the idea of leaving Canada on its own and me enjoying my life and wondering about how the system would be in 20 years. I don't think I could have lived with that, and I certainly couldn't sleep that night. And I want to talk a little bit about why that is. What is it about our system? And Moses gave you some examples. What is it about our system that we hold so dearly and covet? People from the outside of Canada think of it as a wonderful. I mean, you look at Bernie Sanders comes here and talks about it in rave reviews. Yet Moses is right. We're not happy with our system. And why is that? Well, first of all, there is growing demand. So the system is under tremendous pressure for new services or additional services or demand for services. Part of it is aging and demographics. Part of it is new therapies. Part of it is stakeholders that want more, physicians that want increased fees. Part of it is new indications. Some of it is around innovation of new therapies like expensive medication. But for a whole bunch of reasons, there's tremendous increased demand on the system. But that's driving increased costs. And so 50% of our budget, about most provinces, is close to 50% of the provincial budget goes to healthcare. Demand for services, that first line, is growing, and different people would put different analysis, or anywhere from 6 to 10%. Let's call it 8%. Let's call it even 6%, which is the federal government view of demand of costs is 6%, but maybe it's 8%. So 8% of 50% of your budget is growing, 50% of your budget is growing by 8% every single year. And our GDP, our capacity to pay, is growing less than half of that, 2 or 3%, if we're lucky. Those lines will never intersect, and we'll talk about that. So increased costs driven by all these new therapies, growing demand, and a care model that was designed in the 60s, when we were a young, healthy population with few new indications and designed for acute care. It's all very hospital-centric, our system, as opposed to where most of our costs are now in chronic conditions. And the care setting is not organized for where all the conditions are, where the opportunity is, and so this dynamic is unsustainable. And this is what kept me up at night that night, is that unsustainable dynamic, and it just keep going is not the answer. If the system just keeps going, it's unsustainable, and we're seeing it every day. You saw it in the election debate that happened just a few weeks ago, and different ideas around it, but it's an unsustainable system. We're already in deficit. The demand for services growing at 6 to 8, 10%, and the capacity to pay growing at 2 to 3%, they will never intersect. We'll never get out of deficit. And mathematically, that's not impossible unless we reform the system. It's not going to be about anything else. And so, oops, I went too fast. So what is that deficit? That's the estimate of the deficit in 10 years in Canada on healthcare specifically. And every time I've looked at this statistic, I've been in healthcare now close to 20 years, every time I've looked at this statistic, the number gets bigger. We continuously underestimate how big our deficit is going to be in the system the way it's currently designed. And are we going to be able to increase taxes by that much? Are we going to increase GDP by that much? Are we going to remove services from other areas, infrastructure, education? I don't know what the answer is, but that's not the answer to have that kind of deficit and budget. And despite the fact that the system needs tremendous reform, we're very slow to adopt it. And I'm going to talk about that, and we're really slow to adopt this because of a whole bunch of reasons that I'll get to. But this is a statistic that really, it's one that's very current right now. So I'm on the advisory board of Canada Health Infoway, federal institution that's trying to bring e-health to the Canadian market, in some places by funding it, in some cases by developing standards around interoperability, in some cases by running it, and of course trying to convince 10 provinces, a whole bunch of stakeholders, LHIN's CEOs, the medical associations, pharmacy associations, and herding cats to try to get e-health in Canada. But in the US, not far from us, 90% of all prescriptions are e-prescribed, 90%. And in fact, in many US states now, it's become mandatory. So it's 100% in those states. In Canada, in 2018, only 3% of our prescriptions are electronic. And there is tremendous evidence that electronic prescribing improves the efficiency and effectiveness of the healthcare system. And yet, because of all sorts of reasons in Canada, not because the technology doesn't exist, not because we don't know what it is, not because we don't know how to use it, not because it's not the evidence is not there, but for all sorts of other reasons, we're not adopting it. And the prognosis for that is that it won't get to double digits for another 5 to 10 years. If we keep on our current path of how we're implementing e-prescribing, very small example of what's really needed in the system and our ability to adopt it and make it ubiquitous, even though this is not innovation. This is not about adopting innovative technology. This is adopting basic technology in this example. And so what is it? And so our current thinking, the way we think and the way the current Ontario election debate went, or the federal election debate went, it's about access. The way we experience these problems and the way we manage the problem in Canada is by, I call it the sledgehammer or blunt instrument of access. So 25% Canadians don't have a family doctor. We need more doctors. That's the answer. ER wait times, the worst in Ontario is now hovering around 10 hours in hospitals for ER wait times. So we need to reduce wait times in hospitals. MRI testing or diagnostics, or the ability to access a long-term care facility. We talked, you saw that they were going to put more funding in long-term care, the ability to be cared for at home. So all this idea of is about how do we manage access, and how we struggle as Canadians is we rile against the lack of access, the problem with access, because that's how we experience the problem with our healthcare system. Because once we have access, we actually have pretty good outcomes in some theaters, but actually very poor outcomes in other areas, particularly around chronic diseases, we have poor outcomes. So how do we think? How does our company, why did I join this company? Why did I come back after that sleepless night? How are we thinking about it, and how I think we should think about it as Canadians, and why I'm so energized and excited about this role? And there's 4 things, in our opinion. The first one is the most basic, is we should put the patient at the center of care. And right now it isn't. All sorts of decisions are being made that don't put the patient at the center of that care. Another stakeholder, the OMA, the health ministry, brand manufacturers, generic manufacturers, companies like ours, pharmacists, other clinicians, nurses unions, public sector unions. There's always another stakeholder that's at the center of a decision. Very rarely is the patient at the center of a decision. An example of that is virtual services. So in some parts of the world, virtual services for medical services, primary care, family doctor, online for your services. But in Canada, in most places in Canada, your doctor will call you and tell you, please come in 3 weeks to get your test results. Why do we do that? We do that because the doctor is only paid if they actually see a patient. They can't actually do that online or on the phone because they're not reimbursed for that. So they choose not to in many cases, and there's no technology to do that. But if it was patient-centric, that's what the patient wants. That's preferable to the patient. We would actually change that and make it available to the patient because that's their preference. And it's just an example of, and there's myriad of examples where the patient is not at the center of care. And then the other 3 things we need to do, and these are big changes for us. Well, first of all, it's about aligned incentives. We have our incentives about how we deliver care, how we triage it, how we access it, is not aligned. And it starts with the patient at the center of care, but patient also in terms of what are our incentives to look after our health? There are none, hardly any. It's really, we all are the same when we hit the healthcare system. Whether we smoked, whether we stayed on our care plan, whether we did a genetic test to do any prevention, whether we managed our nutrition, whether we did or we didn't, we hit the healthcare system the same way, even though it might cost 10 times more. But if you have 3 accidents in your car, your rates go up. And so this idea of aligned incentive, but there's other examples. What's the incentive for an employer? I have to face that. I'm running a company, and we have 13,000 employees in Canada. What is my economic incentive to hand that group of employees to the public health system healthy? And you'll see a great disparity between when people hit the age of retirement and how much more they cost the system. And a lot of people attribute that with aging. It's actually much more attributable with prevention and maintaining good health during your employed years. And there is no incentive for an employer to hand retired employees to the health system that is going to cover 100% of their costs in a healthy manner. There's no incentive for a physician to have a healthy patient. They're paid by professional act. They're not paid for on the basis of if you have healthy patients. What's the incentive for a hospital not to allow a readmittance? 16% of Canadians are in hospital. 16% of hospital admittances are due to a medical error. Any one of us would run our business with 16% error rate, our businesses would fail. So aligned incentives. New settings of care. Justin Bates is going to come up, talk about pharmacy as an example of a new setting of care. And the current system, which is acute-based, hospital-centric, needs to be community-based and closer to the patient. Pharmacy is an example of that. Reform around primary care, virtual services, using technology like remote diagnostics and remote monitoring are all examples of changing the care setting to align with where the problem is, which is mostly chronic versus acute conditions. And then finally, adoption of technology. We've heard a lot about that, but we are very slow in Canada to adopt technology. In some areas, we're better, but in most areas, we're well behind in terms of the adoption of technology in order to make the system more effective and more efficient. And effective means better patient outcomes, better health outcomes, and efficient means at a lower cost. It is not a paradox. It is absolutely possible to have better health outcomes with less money. It is not a paradox. And there's lots of examples, but I'll give you one that's going to resonate with the next speaker, is I lobbied, not me, the industry lobbied for about 7 or 8 years to convince Canadian health ministries to allow vaccinations for the flu to happen in pharmacy. The rest of the developed world was actually already there. Canada was behind. And after about 8 years, there was an agreement, and many provinces adopted. Some provinces now do all inoculations. Some provinces only do flu. Some provinces still don't do it. And what did that do? It provided access, so you could wait 10 minutes in line at your local pharmacy versus make an appointment 3 weeks in advance, wait 4 hours at a doctor's office, and not get a flu shot. And what happened is low inoculation rates and bad population outcomes at a higher cost. What's happening now, where this is allowed, lower cost, higher inoculation rates, less ER visits, in fact, less deaths for a system that is lower cost with better health outcomes. And there are a myriad of examples on that if we do these 3 things. And in that example, all 3 of these things were done. So why should we do this? I mean, there's an economic reason, there's a fiscal reason to do it, there's health outcomes. But really why we should do it is currently the system is held together by heroes. People that choose to go into the public sector, people that become health ministers, physicians that go above and beyond the constraints that they have, nurses that work the second shift, hospital administrators that have to deal with all the different stakeholders they have to do. There's Canadian heroes that are keeping our system working despite all those problems. And we owe it to them to make a better system. We owe it to ourselves, but we owe it to them. And they're the ones that got me back in this role. We have a company that has the scale, capability, and wherewithal to make a difference, but we need some help. And we need help by Canadians, and we need help by policymakers to make that happen. And that's what's got me energized. That's why I now sleep at night, because I'm participating in the solution. We have a lot of work to do, and we've built this great team in Canada to help do it. And let's support these heroes to do that. And that's about Healthcare 2.1. Thank you.
So I'm for Dominic Pilla as health minister. Do we have a government somewhere that we can...
I'm going to stay in my job.
That's wonderful. Let's get a picture.